Hello everyone, my name is Caleb Sorenson and I'm a Master of Public Health student. I'm speaking today from Lekwungen territory, the traditional lands of the Songhees, Esquimalt, and Wasanich peoples, lands that I'm grateful to live on today. I completed my practicum with the First Nations Health Authority working on a project focused on Indigenous knowledge translation. Before I discuss this project, I want to locate myself in this work. I am of Norwegian ancestry. My great-grandparents settled in Canada in the early 1900s. I've included some photos of the farm in the Alberta prairies on Treaty 6 territory near the community of Viking where my great-grandparents on my dad's side settled on. This land is still in my family today, 5 generations later, and has afforded my family many opportunities when they left a situation of poverty in Norway. But that land was made available through colonial policies and the displacement of Indigenous peoples. So I say that because I approached this topic of Indigenous knowledge recognizing that my understandings of knowledge and education and health are through colonial and Western understandings. So I approach this topic with great humility. I am very grateful for what I've learned about Indigenous approaches to health and Indigenous research methods through my MPH, as well as through my experience at FNHA. And today I am humbly sharing some reflections and lessons that I have learned. My practicum placement was also with the First Nations Health Authority, and it was with the Communicable Disease and Population and Public Health team within the Office of the Chief Nursing and Allied Health Officer at FNHA. This team supports First Nations health by developing resources and guidance related to immunization, maternal and child health, sexually transmitted and bloodborne infections, communicable disease management, and tuberculosis. Resources designed from this team are for community health nurses to support their work in First Nations, as well as community leaders and the creation of public-facing materials. To support this work, the team recently hired a knowledge translation specialist who I worked with and learned a great deal from during my practicum placement. Together, we were interested in what the literature could teach us about Indigenous knowledge translation and how those lessons might inform public health resource development. My project during my placement was a literature review on Indigenous knowledge translation with a focus on First Nations perspectives on knowledge sharing, reciprocity, community-led approaches, and culturally appropriate ways of sharing health information. My attention was to identify common themes and lessons across different contexts and projects. Methodologically, I aim to identify and analyze approximately 20 documents. I use a broad range of keywords related to Indigenous knowledge translation and search multiple databases to include both academic and gray literature. Since discourse about Indigenous knowledge is not limited to academic literature alone, especially with historic and ongoing publication biases against Indigenous research methods. The 20 documents I selected to analyze include 7 sources that focus more on aggregate and conceptual information, while the other 13 focus on individual studies and cases. Through analysis, I synthesized themes across these sources. Before getting into the findings of Indigenous knowledge translation, I want to provide a bit of background on knowledge translation. The Canadian Institutes of Health Research defines knowledge translation as a dynamic, iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve health. Knowledge translation tools, resources, and audiences vary greatly. In practice, knowledge translation can take the form of infographics, workshops, video, curricula, practice guidelines, and story-based resources. Knowledge translation tools are designed for a wide range of audiences, including community members and the general public, as well as healthcare providers, policymakers, and researchers. While knowledge translation is often valued in health practice as being very practical, it also exists within colonial systems of research and healthcare. Western research traditions are rooted in positivism, where knowledge is seen as objective, measurable, and existing independent of the people or places from which it emerges. This framework often assumes that knowledge is a one-way transfer from expert to recipient, and that information transfer alone can lead to change. These assumptions have many harmful implications. They devalue lived experience in Indigenous knowledge systems and research methods. They ignore the intergenerational effects of colonialism and instead support a deficit-based and paternalistic understanding of Indigenous health. This background is important when considering how Indigenous knowledge translation differs. In my analysis of the articles I read, I identified 7 key themes which I will briefly discuss while acknowledging that each of these themes alone could have their own presentation. First, on relational principles. Indigenous knowledge is grounded in respect, relevance, reciprocity, and responsibility. These principles ensure work is done ethically with relational accountability. Context and language. Knowledge translation must reflect local cultures, languages, and meanings. Third, on experiential and community knowledge, lived experience and community experience are central. This reflects why participatory methods are foundational in Indigenous research. Fourth, reciprocal and multi-directional sharing. Knowledge flows between elders, providers, researchers, and community members. In health settings, Indigenous knowledge translation is not only about teaching, but it is also about learning. Fifth, on diverse knowledge translation tools, there was no single most effective knowledge translation tool identified in the literature because different tools will better serve different audiences, contexts, local cultures, and protocols. But examples of potentially more accessible and culturally aligned approaches include visual and narrative tools, storytelling, videos, interactive workshops, and including elder teachings. Six, on the inclusion of Indigenous peoples, meaningful involvement in Indigenous peoples is in the development of knowledge translation resources is critical, and this can include many different ways, including engaging and partnering with elders, knowledge keepers, and community members. And seventh, on the responsibilities of non-Indigenous peoples. For non-Indigenous practitioners, the literature emphasized the importance of cultural humility, including cultural safety training, continually practicing self-reflection, and researching and learning about cultural contexts. This framework, conceptualized by Legault, Olson, and Matai, resulted from a shared lessons from an Indigenous Wellbeing Conference in Kelowna a few years ago. And I think this image of this framework embodies many of the themes I have discussed. Different types of knowledge, whether that comes from research, community, or medical practitioners, well-being practitioners, overlap with each other. And also through that overlapping, one person can have more than just one identity or bring forward one part of knowledge. The framework is embedded with the ethical principles I spoke to earlier, and the circular shape of it shows like the iterative approach to the generation and sharing of knowledge. The literature offers many valuable teachings of Indigenous knowledge translation. Many of the examples that I researched and analyzed were community specific, which does differ from the province-wide mandate of organizations and teams, such as the Communicable Disease and Population and Public Health team at FNHA that I was placed with. However, there are still important takeaways and lessons to consider in applying the findings to public health practice resource development, including that ensuring diverse Indigenous inclusion in resource development, uplifting Indigenous knowledge and ways of being, recognizing that knowledge translation involves reciprocal sharing of knowledge, so including ways to learn from communities and receive feedback, and even with standardized materials, considering ways to design tools so that they can be adapted or contextualized locally. Some reflections on core competencies. I will just say that I really enjoyed our keynote presentation because with working in an Indigenous-led organization and considering what public health can learn from Indigenous health, in reading the competencies, what stuck out with me is in the communication competency is the practice of active listening. And in the reflections that I had already written, I reflect on the COVID-19 pandemic where public health was experienced as a top-down experience from the pulpit, where there is so much of being reactive and then listening to what it is that communities need. And similarly, through partnership and collaboration, I think this is an important of just like a participatory process that does support the self-determination of Indigenous communities, but also a frustration that we've heard about bureaucracy and policy making through these presentations in the last 2 days is how like fragmented and siloed that it can be. Frankly, no offense to our field. There are many publications, there are many reports. I think taking time to make sure others are included and that are relevant to the work that we are doing is a worthwhile process. And thank you all for listening. I'd like to close by thanking Hamani, Cheryl, and Michelle for welcoming me as a practicum student and for their mentorship, guidance, and support over the past few months. And I'd also like to thank my partner Janelle, who's here, whose professional and academic experience has included many community-based research projects. So I learned a great deal from during my master's. And with that, final presentation.